Welcome! The following presentation from Answers in CME is part of an educational activity titled The Next Era of Chronic Kidney Disease Management in Type 1 Diabetes, Evolving Care Strategies to Improve Patient Outcomes. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated.
Hello, I'm Janet McGill, Professor of Medicine at Washington University in St. Louis. Today, we'll be discussing the management of chronic kidney disease in type 1 diabetes and how to enhance cardiorenal outcomes while addressing the unique pathophysiology of type 1 diabetes. Chronic kidney disease in type 1 diabetes is a major driver of poor health, of morbidity, and mortality. Chronic kidney disease can show up as soon as 15 years after diagnosis in patients with very high A1Cs and poor control of other risk factors. In those with better control, we see evidence of reduction in kidney function is about 30 years. That being said, chronic kidney disease in type 1 diabetes is very common. It's a very feared complication. Kidney function in type 1 diabetes can decline either very, very rapidly in those who have high levels of proteinuria or slower in those with lower levels of proteinuria. The important thing is to understand who has chronic kidney disease, who is at risk for chronic kidney disease, and what that tells us about their overall risk of heart and other morbidities and mortalities. Understanding how to screen and then how to diagnose chronic kidney disease in people with diabetes requires two kinds of tests. First is a spot urine called the albumin to creatinine ratio. Can be done any time of the day. It's more likely to be high in the morning. So if you see some fluctuation, testing it at the same time of day might be helpful. But the most important thing is simply to test UACR beginning at 5 years after diagnosis of type 1 diabetes and continue testing at least annually. The UACR testing should be accompanied by a chemistry that measures creatinine and estimated GFR. CKD diagnosis is defined as persistent UACR greater than 30 milligrams per gram or persistence of an estimated GFR less than 60 milliliters per minute. Unfortunately, recent data shows that only 32% of patients with diabetes have ever had albuminuria testing. We can do better. Let's talk about the unmet needs in the management of chronic kidney disease and type 1 diabetes. The high risk of morbidity and mortality is in part attributable to lack of effective proven therapies. Until recently, there were no new treatments for chronic kidney disease in type 1 diabetes since the captopril diabetic nephropathy study, which was published in 1993. We need validated surrogate endpoints to facilitate trials for chronic kidney disease in the smaller type 1 diabetes population. These therapies should be shown to be effective, and we need to consider therapies that have been shown to be effective in type 2 diabetes, re-evaluating the risks versus benefits and testing them for efficacy in type 1 diabetes. In the next session, let's examine the underlying biology that drives chronic kidney disease and type 1 diabetes and how that pathophysiology informs potential treatment approaches. In session 2, we'll talk about the biology driving chronic kidney disease progression. A question I'm often asked, is it the glucose? Does poor glycemic control matter in patients with diabetes? The answer is absolutely yes. We know from studies in type 1 and type 2 diabetes that those with worse glycemic control have more rapid decline in their estimated GFR. So even after they have chronic kidney disease, poor glycemic control contributes to more rapid progression. So are there differences between type 1 and type 2 diabetes? The hyperglycemia affects both populations. Hypertension also affects both populations. But what's fascinating is that in type 2 diabetes, many studies of people with chronic kidney disease and type 2 diabetes show a duration of about 15 years. In type 1 diabetes, we see the same amount of proteinuria, the same eGFR in folks who've had duration of about 30 years. Now, the patients with type 1 diabetes are younger and they've had diabetes longer, but otherwise, when we begin these studies, the patients have similar characteristics of their kidney disease, similar albuminuria and similar blood pressures, similar A1C, but the age is different and the duration is different. The treatment classes for chronic kidney disease in diabetes target various aspects of the disease pathophysiology. RAS inhibitors affect hyperfiltration, endothelial dysfunction, cardiac remodeling, and are important early and continuously in our management. The newer therapies include SGLT2 inhibitors that impact hyperfiltration. They reduce proteinuria, reduce inflammation and fibrosis, prevent or reduce progression of chronic kidney disease. In people with type 2 diabetes, as you know, SGLT2 inhibitors now are part of guideline directed therapy for those with type 2 diabetes or without diabetes who have proteinuria as part of their chronic kidney disease. New data shows that GLP-1 receptor agonists also reduce progression of chronic kidney disease. They have other beneficial effects like reducing weight, dyslipidemia, affect endothelial dysfunction, and have been shown to affect long-term cardiovascular outcomes. The last category of targeted therapies includes the nonsteroidal mineralocorticoid receptor antagonists. They affect inflammation and fibrosis, endothelial dysfunction, reduce proteinuria, and reduce progressive loss of chronic kidney disease. In the next session, we'll talk about the emerging strategies for chronic kidney disease that have been shown to have beneficial effects in people with type 1 diabetes in particular. Let's talk about current and emerging strategies for chronic kidney disease in type 1 diabetes. The KDIGO heat map tells you how to think about the risk of progression based on the amount of albuminuria and the eGFR. We now categorize chronic kidney disease into stages G1 through G5. G1 being normal, G5 being kidney failure, but also albuminuria categories A1, 2, and 3. When the patient has more than 300 milligrams per gram of creatinine, it increases their risk of rapid progression and loss of kidney function. On the heat map, you will also see numbers 1, 2, 3, and 4. These numbers refer to the frequency of repeat testing. In those who are at low risk, colored green or yellow, it's appropriate to retest once per year. Once a patient is showing signs of albuminuria in combination with lower GFR, stage G3A2, for example, that patient should have follow-up testing twice a year. In those with high levels of albuminuria, greater than 300 milligrams per gram, we're no longer screening. We're now treating those patients and following them. So the word screening no longer apply. We need to repeat testing twice a year and then go to 3 times a year when eGFR is reduced so that we can identify problems such as electrolyte abnormalities or rapid progression. Once a patient reaches stage G4 or severely decreased eGFR, that patient should be referred and should have more frequent testing of their serum creatinine, electrolytes, and maybe CBC, UACR to identify not only rapid progression, but other problems that they're going to encounter. The key drug classes for managing chronic kidney disease and diabetes include RAS inhibitors. RAS inhibitors also have a prevention role, so should be started with moderate elevations in blood pressure and continued even as the patient develops declining kidney function, albuminuria, nonsteroidal mRNAs are recommended if the estimated GFR is greater than or equal to 25, UACR is greater than 30, and potassium is less than or equal to 4.8. SGLT2 inhibitors and GLP-1 agonists are not approved or recommended for those with type 1 diabetes. Both have been tested in people with type 1 diabetes, and in SGLT2 inhibitors, there is a 2 to 4 times risk of ketosis and diabetic ketoacidosis. With GLP-1 receptor agonists, there is also more ketoacidosis in early trials. These are being revisited, and we're going to talk about that. In the next section, we'll talk about how to leverage type 2 data to inform chronic kidney disease care in patients with type 1 diabetes. In session 4, we'll talk about how to bridge the evidence gap, leveraging type 2 data to inform CKD care in type 1 diabetes. The SGLT1/2 inhibitor sotagliflozin was tested in 1,575 patients in the Tandem 1 and Tandem 2 clinical trials. 13% of the participants had UACR of 30 milligrams per gram or greater. Subsequent analysis showed that sotagliflozin at both 200 and 400 milligrams per day reduced albuminuria, but it was not significant. Serum albumin increased a bit, which would be expected, and we also saw this early dip in eGFR, which tells us that the SGLT2 inhibitors are acting in the manner that we expect them to. This is suggestive that SGLT2 inhibitors will have similar effects in type 1 diabetes as type 2 diabetes, but it's clearly not the data that we need to be confident. In the DEPICT trials of dapagliflozin in type 1 and type 2 diabetes, secondary analyses were also undertaken. 164 patients with UACR of 30 or greater took either dapagliflozin 5 or 10 milligrams and were compared to 87 patients with elevated UACR who took placebo. There was a reduction in UACR in all three groups. Because of the reduction in the placebo group, 5 milligrams was not significant. The change with the 10 milligrams, we cannot call it significant, but did not cross confidence intervals. So again, very suggestive data. However, the data that we have are cohorts of larger trials and were not designed to be definitive data. Consequently, there is currently an ongoing clinical trial called Sugar and Salt that is testing sotagliflozin 200 milligrams daily in people with type 1 diabetes and UACR greater than 100 milligrams per gram. That study will take a couple of years to complete, as it is testing both reduction in UACR and progression of chronic kidney disease defined as change in estimated GFR. So we'll have more data once this study is completed. Concerns include similar adverse effects and side effects that we see in patients with type 2 diabetes. For example, volume depletion, genital infections, urinary tract infections, and perhaps increased risk of fracture. The big concern about SGLT2 inhibitors in chronic kidney disease and type 1 diabetes are ketosis-related events. DKA with SGLT2 inhibitors occurs, can be prolonged in some cases, and can be severe in some cases. The nonsteroidal mineralocorticoid receptor antagonist finerenone has been tested in over 13,000 patients with type 2 diabetes. In the composite analysis, kidney failure was reduced by 16% with finerenone versus placebo. A sustained 57% decline in estimated GFR showed a 30% reduction in risk, and there's a 47% reduction in renal death. So we know that finerenone is effective in reducing risk of renal progression and mortality in patients with type 2 diabetes. The safety of finerenone has been very well defined in the fidelity pooled analysis. The biggest difference occurs in investigator-reported hyperkalemia, which occurred in 14% of those on finerenone compared to 6.9% of those on placebo, and caused permanent discontinuation in 1.7% compared to 0.6%. There were no deaths related to hyperkalemia in either group. The fidelity pooled analysis provided a very interesting opportunity to translate data from type 2 patients to those patients with type 1 diabetes. This is the basis for the design of the FIND-1 clinical trial that was recently completed in persons with type 1 diabetes and chronic kidney disease. Looking ahead, what are the innovations on the horizon for chronic kidney disease in type 1 diabetes? One important question is whether UACR can be used as a bridging biomarker for kidney outcomes. We reviewed the fidelity pooled analysis in 13,000 patients that showed a reduction in composite kidney outcomes. In-depth analysis showed that reduction of UACR by finerenone compared to placebo, and in particular, the early reduction of UACR, accounted for 87% of the composite kidney outcome. So if we know that reduction in UACR is related to the longer term hard outcomes, such as reduction in end stage kidney disease, reduction in progression of loss of kidney function, and reduction in renal death, then it's considered possible to use reduction in UACR as a bridging biomarker. This has been utilized in the design of the FIND-1 study that tested the efficacy of finerenone on UACR reduction in persons with type 1 diabetes and chronic kidney disease. FIND-1 randomized 242 patients with type 1 diabetes to finerenone 10 or 20 milligrams or placebo. The outcome was reduction in UACR over a 6-month period. Finerenone reduced albuminuria by 25% compared to placebo over a 6-month period in patients with type 1 diabetes and albuminuria. The safety of finerenone was found to be very similar in patients with type 1 diabetes to those with type 2 diabetes. Serious adverse events were roughly equal. Hyperkalemia occurred more often in people taking finerenone compared to those taking placebo. Additional studies are underway. The most notable is the sugar and salt clinical trial that will test sotagliflozin versus placebo in a similar population. The study will be longer and test both albuminuria reduction and preservation or prevention of progression of loss of estimated GFR. That study will report out in a couple of years, so stay tuned. The GLP-1 receptor agonist semaglutide is also being tested in people with type 1 diabetes and chronic kidney disease in the remodel T1D study. Again, that study will test longer-term outcomes and will report out in a couple of years. The good news is that there is greater interest in kidney disease in people with type 1 diabetes. Therapies are being tested, studies are being done, and we'll have more data. For now, what we know is that finerenone is effective in reducing albuminuria and that this effect may translate to longer-term protection of declining GFR and progression to end-stage kidney disease in people with type 1 diabetes.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.